Thank you, Mark. That was an excellent description of what happens at the restorative surface, and that is the crucial part of how we adhere a crown to a tooth, because cementation really is no longer just enough. Now, when we take a look at cements, the relation we're looking at is the relation between the restoration and the tooth, and as much as possible making that an invisible supragingival type of margin which can be easily maintained by the patient. So let's just start off again, and I'm going to mention that it's very important when you are cementing a restoration to, number one, have a surface that can be cemented, in other words a restoration that can adapt to the cement, and to have a tooth that can adapt to the cement, and then of course the material in between that will adapt to both sides. Here we're looking at a cementation area where we have a crown or a veneer that's going to be fitted over an abutment, and the ideal is to have a ceramic restoration in this case, adapting to the existing remaining tooth structure as closely as possible in terms of physical relationship, no gap, and in terms of color as well. What are the materials that we can use? What are the techniques that we can use? And how do we make it work? So what is cementation? There are various kinds of cementation. Much of the cementation that we learned in school is a little bit different. We'll go over that in just a moment. Where do we want to place our margins? Supragingival, subgingival, at the gingival margin. How do we prepare our teeth, and how do we prepare our crowns? And we've just heard Marc go over that. And why do we use certain materials? The materials that we've had over the last 8 or 10 years have been fine, except for the alumina and zirconia crowns that are now so much a part of our restorative process, number one. And number two, for those areas of repair which have always been very unlikely to succeed without the tribochemical treatment that we are now looking at. When we take a look at the cements, as much as possible, we want to simplify. We want to eliminate technique sensitivity, eliminate multi-step cements, and go with single-step resin cements if possible. Hands required. If you're using multi-step cements, you need 2 to 3 pairs of hands, 1 or 2 assistants, because you have to prepare the tooth at the same time that you prepare the crown, at the same time that you mix the cement. With one-step resin cements, once you've prepared the crown, then very often only 1 or 2 pairs of hands are required. The number of steps, with most of our multi-step cements, multi-steps means 5 or more steps. The auto-mix direct resin cements are typically single step. Much easier, much more predictable, much less likely to have any technique sensitivity. And in terms of time, when we're taking a look at a multi-step cementation, it's often 15 minutes plus, including cleanup. For the resin cements, it's 5 to 7 minutes, including cleanup. First question that we had before: what is a cement? Well, there are many cements, materials for relating 2 or more materials such that they stay together, incorporated as a single unit. That's the basic definition of a cement. And the cement, ideally, we don't think too much about it, but we want to have an area like this, if we can, and cement a restoration there, which is relatively invisible, long-lasting, resistive to forces, and unlikely to break down or to redecay. And you'll notice that most of my margins are supragingival. Why are they supragingival? For the simple reason that a subgingival margin is impossible for a patient to maintain. You can't maintain it with brushing, you can't maintain it with flossing on the buccal lingual surfaces. In fact, you can't maintain it in any way. So that's likely to break down. A supragingival margin is accessible to floss, it's accessible to water flossing, it's accessible to toothbrushing, and a variety of other procedures, including the chewing of gum. So it's likely to be kept cleaner, likely to be longer lasting. The issue is we have to make sure that we can do it aesthetically so that the patient will accept that. Now, if we take a look at the next question, adhesion versus luting. Cements can either adhere a crown or they can lute. A luting cement is defined simply as a material that relies on mechanical retention. It's based on reactive or alkaline fillers. And here you see an example of a luted porcelain fused to metal crown. A luting material simply takes the place and the space between two dissimilar materials that have a gap in between them. It doesn't adhere, it doesn't bond to either surface, and it can dissolve. If it dissolves, the restoration fails. If it doesn't dissolve, the restoration is likely to last. An adhesive cement is stabilized by adhesive bonding to both the restoration and the tooth surface. Typically relies on anhydrous and silanized unreactive fillers for its activity, and it bonds to both the tooth structure and to the crown, and in that way creates a monoblock, as Marc was describing a little bit earlier. This monoblock is simply a single structure, so the entire restored tooth, from the crown through the cement into the remaining tooth and the roots, is now acting as a single unit, very similar to what the natural tooth behaved like before it was destroyed by decay, before it was cut down for a crown, and before it was restored. So that's really the ideal that we are looking for. Luting cements rely on mechanical retention, and that is very technique sensitive. We need long axial walls for the retention. We need a slight taper of ideally 6 degrees. When was the last time any of us measured our tapers of our preparations to see that they were 6 degrees? How can you measure? Not easy. And you need a precise fit. You need to have an excellent lab in addition to an excellent impression system that'll give you an ideally 30 but perhaps up to 100 micron fit. 100 microns is 1/10 of a millimeter. You're starting to feel that with your Explorer, and by then it's no longer a really well adapted crown. Conventional cements fill the gap between the tooth and restoration without adhering to either side. Adhesive cements are different. Adhesive cements are stabilized by adhesively bonding to both the restoration and the tooth. And we can get much better margins, as you can see over here, much more continuous margins, margins that are not only physically better, but aesthetically better as well. We need adhesive surfaces on both our tooth and the restoration. And this is where tribochemical treatment comes in, because many of our lucite-based ceramics can be bonded, can be micro-etched or fluoride etched, and in that way bonded to the tooth structure. But the alumina, zirconia, and most metal surfaces cannot be treated by hydrofluoric etching. So you need adhesive surfaces. You need a controlled environment, no moisture. This is where cord lasers come in, and so on. Adhesive cements fill the gap between the tooth and bond to both the restoration and the tooth, creating the monoblock that we've mentioned earlier. Now, which cement should I use? Depends what procedure you're doing. Depends whether it's a crown, bridge, veneer, onlay, or a post-cementation. And because of that, you will use either light cure cements. For example, for veneers, we use light cure cements. Why? Because light cure cements don't darken with time. Most of our dual cure cements darken and yellow with time. And for that reason, we can use them under crowns, we can use them under zirconia, metal, alumina, without any difficulty. But we can't use them under veneers. It also depends on the tooth and the tooth structure that's remaining. Is the tooth vital or non-vital? If the tooth is vital, you want to make sure that you're going to use a non-irritating material. Non-vital is less critical. This is interesting because our zinc phosphate cements that we used to use for, well, pretty well 100 years within the profession, when you apply them to the tooth structure, they were at a pH of slightly over 1. Very, very acidic. When they stabilized after polymerization or setting, they stabilized at around 4.5 pH, which was still very acidic. The other issue is long-term or short-term. There are different requirements for long-term and short-term type of cementation. Shade is also an important issue. For short-term, not so much. For long-term, critical. Now, it also depends on the restoration, and there are provisional restorations, which we're not going to discuss here, but definitive restorations, of course, are made of different materials, and these materials will dictate the type of cementation procedure you use. For example, if you use metal, you should be using tribochemical treatment. Ceramic, not a problem. Composite, not a problem. Alumina and zirconia, definitely use the tribochemical treatment as well to make sure that you maximize your bonding strength. Which cement should I use? Well, that is a personal preference, but you want to see whether it's a long-term or short-term cement. In the long term, you want something that's retrievable or non-retrievable. Generally, our resin cements are non-retrievable. You have to cut them off, but that's perfectly acceptable because it's unlikely that you'll ever have to do that. Short term have to be retrievable by their very nature. Eugenol, if it's left on the tooth, will interfere with the resin cementation of the crown. Non-eugenol will not interfere with the resin cementation of the crown. However, non-eugenol cements don't usually last very long, and patients often come back after a day or two because the non-eugenol temporary cement has detached. So the dentist's dilemma is the selection of a cement for emotional attachment to historical strengths like zinc phosphate, or selecting a cement for its positive properties and long-term in vivo strengths. So I'm going to take a very brief look at the categories of cements and go through some of the things that we have available. Here's sort of a listing of the cements, and you can see our prejudice, which is resin cements over here. We're looking at total etch and self-etch resin cements. But before we go there, let's take a look at the positives and the negatives of the various other cements that we have available to us. Cements that are available, zinc phosphate. The positives are that we've been using it over 100 years. They've been used for both metal, full crown, bridges, and ceramics, although not too successfully. Good compressive strength, good film thickness. The disadvantages or negatives are there's tremendous amount of post-operative sensitivity with vital teeth, low hardness, high solubility, virtually negligible tensile strength, and no chemical bond to either the tooth or the restoration. And these were used, but they've really gone out of style. The bond strength of zinc phosphate to cement to enamel, 0 megapascals. Dentin, metal, and ceramic, all 0 megapascals. It's a eluting cement, doesn't impart any adhesive advantage whatsoever. This is a permanent cement, but there is no adhesion, and the permanent is in italics and in quotation marks. Zinc polycarboxylate was developed about 30-40 years ago, and it has an advantage in that it releases fluoride. It has little sensitivity, used for metal and full crowns and bridges, and it has a lower compressive strength than zinc phosphate. The reason that it was developed is it's less sensitizing to the tooth structure than zinc phosphate, but it's also a lot weaker. High solubility, low hardness. The film thickness is problematic, low tensile strength, and can deform under loading. So when the patient bites down on it, they can often deform it. Not used very commonly these days. It can be used as a long-term provisional for implants, but there are many objections to it. Glass ionomer cements have been used for 20 years plus. They release fluoride, medium strength. They have a weak bond to enamel and dentin, and that's one reason I can never have understood. I never understood why people use them. They have a weak bond to enamel and dentin. They are very biocompatible, however. There's very little post-operative sensitivity, but they have sensitivity to water and early moisture. They're sensitive to mechanical loading, and they have a very, very low tensile strength. And generally, the early glass ionomer cements that were available in the late 80s and early 90s, every restoration that I cemented with them failed. So I would not recommend these. They're popular but weak and soluble in oral fluids, not our ideal cements. The post-op sensitivity is a problem, and the sensitivity to water and early moisture is a problem. Also, they don't harden to full hardness for at least 24 hours, by which time the saliva has had a chance to do its bad or to wreak its bad effects. Resin-modified glass ionomers have been available for about 15 years. Fluoride release, medium strength, little postoperative sensitivity, usable for metal full crowns and bridges, but not indicated for ceramics because the powder is moisture sensitive, they swell after cementation, and if you put an all ceramic over a tooth structure with a resin modified glass ionomer, the cement swells, expands the ceramic and breaks it, and that is exactly what happened to me and to many others in many cases, so I would not recommend these materials. Compomers, the adhesives, are fine. They require pre-treatments, low solubility, good mechanical properties, and they work for metal composite, high-strength ceramics, low release of fluoride, moisture sensitive, and we don't have that much experience with it. Good mechanical properties, but really hasn't made a major impact. The moisture sensitivity is a major issue. Composite resin cements have been around for about 25 years. High adhesion properties, high hardness, low solubility, all of these are good things. High mechanical properties, the same materials we use for posterior restorative materials, excellent aesthetics. But the older ones required separate etchers, primers, and adhesives, no release of fluoride. You have to remove the excess early, especially interproximally or underneath a bridge, and occasional post-op sensitivity if you have to etch the tooth if it's a vital tooth. All restorations are fine, except, of course, for the zirconia and the alumina restorations. The fact that they require separate etchers, primers, and adhesives is certainly not a positive. Now we come to the tribochemical treatment plus resin cement that we have with Siljet, answers the questions that we have for alumina, zirconia, and metal restorations and repairs. More than 15 years of experience, high adhesion, high hardness, low solubility, high mechanical properties, good aesthetics, because we can use any particular resin cement that we choose to, any one that works in our own hands, and we don't have to use the fluoride etchers in the mouth, and that's very important for repairs. You don't want the very acidic fluoride in the mouth. Even if you protect the patient's mouth very well, you're always running a risk. And there's no postoperative sensitivity. The tribochemical treatment doesn't affect the cementation process at all. You use whatever resin cement you want. All you're doing is you're making sure that you cement to your alumina, zirconia, and metal restorations and repairs as well. No hydrofluoric etchers, and that's the major advantage in repairs. Color matching at the margin. How do we color match at the margin? Well, generally speaking, this depends not on the tribochemical material, but it depends on your resin cement. What we found is we use a white opaque cement that looks more or less the same color as the crown. That'll show up as a white line. If we use a yellow or brownish cement that matches the tooth color, then it's a problem because it's going to look too yellow at the crown cement interface. On the other hand, if we use a translucent cement, it can blend in very nicely and create a gradient between the root structure and the crown color, as you can see over here, where the transition is virtually imperceptible. And this is what we use. This is what you've seen on a couple of the crowns that we've shown you over here, and this is the best bet. So translucent cement, probably about 95% of the cases. If you need to cover a darker root or darker post or core, definitely go with a zirconia crown. And here we have a fairly dark tooth, but we're going to match it at the margin super gingivally. We take the all ceramic zirconia crown. We're going to treat it with the tribochemical function, use our favorite cement and cement it on, even though the clinical crown is quite short in respect to the length of the tooth. The crown works out very nicely and aesthetically, and it's going to be tremendously strong. And here you can see the final result in a close-up. Aesthetically, we don't give anything away, and we've gained a lot of strength. Postoperative sensitivity, generally tribochemical treatment will not solve it one way or another way, doesn't have any effect. But if you use a one-step resin cement where you don't etch a vital remaining tooth, you're most likely not to have postoperative sensitivity. And if you use a cement that doesn't shrink, that'll also improve your chances. So those are two things that you're looking for. And now I'm going to hand it back to Marc.